Thank you very much, chairpersons. My heartfelt thanks to Dr. Manoj and Dr. Purvi and the entire team. Can I request everyone at the back to please come inside and close the door? Now, after listening to these mind-boggling talks of the new generation anti-obesity, anti-diabetic drugs, I will take you in next 15 minutes to the basics, and that is very important for all of us. And the topic given to me is the dermatological manifestations of diabetes. When a diabetic patient comes to us, the dictum is that we must examine the patient thoroughly. Then only we can pick up these things. Or we ask the patient some leading questions also, so that we come to know that what exactly the patient is suffering from in relation to the dermatological. So, can the integument be the curtain raiser for poor glycemic control? If the glycemic control is not good, then definitely these symptoms appear and the signs which we have to look for. The incidence is 30 to 70% of diabetics in different studies, and at times they may precede the development even before the development of clinical diabetes. Prevalence is similar in type 1 and type 2 diabetes, and they are more common in type 2, whereas autoimmune related lesions are more common in type 1. Good metabolic control may prevent and help cure some of these. If we look at the cutaneous markers of diabetes mellitus, we can classify them into the cutaneous manifestations, cutaneous concurrences of diabetes, then diabetes associated with dermatological pathologies, and the diabetic therapy causing cutaneous complications. This is the etiopathogenesis, and the seat anchor is the hyperglycemia. There occurs the endothelial metabolic dysfunction leading to retinopathy, neuropathy, nephropathy, and other vascular complications. And we can see that these are the basic things for anything related to the complications of diabetes in all systems. The pathways are different: the polyol pathways, the hexospin pathways, protein kinase C pathways, and AGE pathways, but I will not go in detail about these. And we can divide them into vascular, metabolic, necrobiotic, bullous, infections, neuropathic, treatment related, and the miscellaneous. And I'll take you through one by one. Diabetic dermopathy, the shin spots, there are multiple round oval macules over the shins, thighs or forearms, hyperpigmented and atrophic. Twice common in older people, should have more than 4 lesions, and they are the marker of microvascular disease, high correlation with the diabetic retinopathy. So if you find these in any of the patients, look for the retinopathy as well, because of the endothelial proliferation, past positive deposits in the BM of the blood vessels, and this is a typical picture of diabetic dermopathy. So you must look for this in your patients. This is another picture. Then second comes the rubeosis faciae, diabetic aurum. Rosy redness of the face, newly diagnosed diabetics, 60% hospitalized patients with diabetes associated with vascular tone and increased viscosity, that is the functional microangiopathy. A sign of poor glycemic control, and with the improved diabetic control, it returns to the normal, and this is the typical feature of the diabetic aurum. Then the erysipelas-like erythema that mimics acute dermal infection by streptococcal bacteria, well demarcated red areas in the feet and leg. They are painless, lack of systemic signs of infections. Compensatory increased peripheral microcirculation caused by decreased perfusion due to the large vessel disease, and this is the picture you can see. These are the erysipelas-like erythemas. Then comes the pigmented purpura. RBCs extravasation from the superficial plexus, then frequently associated with the diabetic dermopathy and increased incidence in elderly diabetics with cardiac failure, marker of microvascular disease. So if we do not know, the thing is our mind does not know, the eyes cannot see. So first we have to ourselves learn how to look for, what to look for, and then of course we have to look for all these into. This is the pigmented purpura. Then comes the periangle telangiectasia, which is very, very common and seen in up to 49% of the diabetics. Megacapillaries and irregularly elongated loops, often associated with nail fold erythema, accompanied by fingertip tenderness and ragged cuticles. Functional microangiopathy, engorgement of venular limbs, tortuosity indicates structural changes, and this is the typical picture of the periangle telangiectasia. Now coming to the metabolic. Acanthosis nigricans, we all know about this. Eruptive xanthomas, yellow skin and nails, and the diabetic scleroderma. Acanthosis nigricans, they are symmetrical, verrucous, hyperpigmented plaques associated with papillomatous skin tags, axilla, nape of the neck, occasionally hands and feet also, mucous membrane. Hyperinsulinemia stimulates IGF receptor on Kc plus dermal fibrillite. And I'll not go about the treatment, because if I start treating these patients, it will be very difficult to cover this topic. This is very, very typical. So always look at the back of the neck, nape of the neck of the patient, and you can find, and this is very typical of insulin resistance. This is at the axillary region. Now look, so these are the common photographs which I am showing you of this acanthosis nigricans. Then the hair and syndrome, hyperandrogenism, insulin resistance, acanthosis nigricans, you can see, and this is the typical picture which has been shown here. Eruptive xanthomas occur in less than 0.1% of the diabetic patients, very uncommon. Crops of small 1 to 4 millimeter yellow papules with an erythematous halo may be pruritic and tender. Buttocks and extensor surfaces of the body appear in association with the elevated triglycerides, resolve with treatment of the increased blood glucose levels and the lipids, and these are the typical eruptive xanthomas. They look like this. Then the yellow skin and the nails. Prevalence is 40% in type 2, more common in elderly, and most evident in the distal end of the helix, caused by hypercarotinemia and protein glycolation end products. Diabetic scleroderma, non-enzymatic glycolation of the collagen. Finger and dorsum of the hands with limited joint mobility. Chest, neck and shoulder, there is increased dermal thickness, difficult to tend the skin, may be subclinical, and it improves with tight glycemic control. So you can see that the tight glycemic control controls many of these features, and they improve with that, and that remains the main important part in the management of this. This is the diabetic scleroderma. Then we come to the necrobiosis lipoidica and the disseminated GA. 0.3 to 0.7% of the diabetics, case series of 107 patients, 60% diabetes, 20% impaired glucose tolerance, 15% patients precede the development of diabetes by more than 2 years, more common in females, Caucasians, type 1, and mean age of onset is around 34 years. Well circumscribed papules, radial expansion, sharply demarcating slightly depressed yellow waxy plaque with erythematous raised border, central atrophy with telangiectasia. And they are pretibial, medial malleolus, chronic course, 20% damage spontaneously in 6 to 12 months, and this is very typical of the necrobiosis lipoidica. This is another picture. Then comes the disseminated granuloma annulare. No clearly established association between localized form and diabetes. Symmetrically distributed on the arms, neck and upper half of the trunk, and less open on the legs. Runs a protracted course, and this is the picture, disseminated granulomatous annulare. So once you have seen these patients, you will never forget in your lifetime. Once you seen one patient, you will remember always, but you have to look for, at least have once a good clinical examination of your patient, physical examination, especially when the blood sugars are not under control, patient coming to you for the first time. This is again another picture of disseminated granuloma annulare. So now come to the bullous diabeticorum. More common in type 1 males, usually confined to the feet, occasionally hands, spontaneous, not related to trauma or infection. Blisters contain sterile clear fluid, rest on a non-erythematous base, and it heals in 2 to 3 weeks without scarring. This is the bullous diabeticorum. You must have seen a number of times. This is another picture. Now 3 types of bullous diabeticorum. Common type is clear sterile blisters on tip of the toes, fingers, heals without scarring and intraepidermal cleavage. hemorrhagic bullae heals with scarring cleavage, multiple tendon non-scarring blisters in sun-exposed areas. Now I come to the infection, which is again very, very important. Infections can be of bacterial, fungal or the viral type, which you must be seeing it more commonly. The common skin infections in diabetic patients are Staphylococcus, furuncle, carbuncle or ichthyoma, then Streptococcal pyogenes, cellulitis and erysipelas, and then Pseudomonas, malignant otitis externa, cellulitis, osteomyelitis, meningitis, cranial nerve palsies, mortality is 50%. So they are more difficult to be treated. Toenail infection and toe web infection is also there, and this is a very, very typical picture of the bacterial infections. Now impetigo, you see the photographs. Furuncle. So what is erythema? Chronic, asymptomatic, symmetric, red, scaly, macerated plaque in the axilla or the groin. Non-clostridial gas gangrene, which is another important region, develops in soft tissue near a gangrenous focus, and the pathogens are E. coli, Klebsiella, Pseudomonas and the bacteroids, and this is the picture of the erythema. Now fungal infections, again very, very common, oral or the perlic, vaginal melanoposthitis, interreginous skin including toe web, paronychia, nail infection, and the dermatophytosis like incidence not increase in diabetes, commonly caused by Trichophyton rubrum. And look at the picture, these are the fungal infections. Very common, very commonly patient comes with, and patient himself tells that, look doctor, what has happened to me? These are again the fungal infections. And look at this, fungal infection. Then very important is melanoposthitis. And this has increased after the use of these SGLT2 inhibitors. If we do not educate our patient properly and the patient does not keep the local area clean, then this is the infection. These are the various pictures of melanoposthitis. This we all have seen the rhinocerebral mucormycosis during the COVID times, especially associated with the ketosis. Black crust, pus in turbinate, nasal septum, palate and the orbit, and a number of patients have been operated for this. Cerebral involvement in 2/3 of the patients. Treatment I will not discuss, and this picture is very common. We all have seen during the COVID times different patients, and especially those patients who have received the oxygen therapy, it was more common into that. Now coming to the viral infections, they are the fulminant herpes zoster. I don't know how much effect the vaccine does in preventing these, but definitely vaccines are for prevention. Fulminant herpes zoster, recurrent herpes simplex infection, and the mechanism behind the cutaneous infection stands as deranged microcirculation, which causes decreased phagocytosis. And this is the picture of herpes zoster. Herpes simplex at the angular region of the lips. Now we come to the neuropathic anhidrosis, hyperhidrosis and the neuropathic ulcers. Anhidrosis, neuropathic ulcer, these are circular punched out ulcer in the middle of a callosity over the metatarsal heads, and if there is involvement of the peripheral nervous system, diabetic peripheral neuropathy, and on the top of that if there is a peripheral arterial disease also, then this incidence increases. Now we come to we treat diabetic patients, and what are the complications, skin complications of the diabetes, treatment related, and one very common, this is the diabetic therapy and the CADRS. But the insulin reaction to the insulin, immediate localized generalized edema, urticaria, delayed itchy nodule 4 to 24 hours after inspection. Then this also we see the lipoatrophy, circumscribed depressed areas after starting the treatment, lipolytic component of insulin preparation, immune complex mediated inflammation, and the lipohypertrophy also. And you must have seen this picture in a number of your patients, those who are on insulin. Now I come to miscellaneous. Vitiligo, localized generalized forms, 1 to 7% in type 1 diabetics, may be a part of the polyglandular syndrome type 1, and treatment again, we don't know about what treatment it is. but this is the common picture which you have seen. So this is also related to diabetes. This is vitiligo. Then lichen planus, very common, and you must know pruritic, pinpoint papular, polygonal, plain topped, violaceous to grey itchy papular lesions. They may be purple at trauma prone sites, Cobner's phenomenon being positive. If you just half a minute more, sir, half a minute. So if the patient start itching, because they are itching, if the patient start itching, the number increases. And this is a typical picture of the lichen planus. Psoriasis, papulosquamous condition, chronic relapsing, trauma-prone sites. This is psoriasis, you all know about that. So the incidence is increased in diabetic patients. So these are the key points we should look for all such type of cutaneous manifestations. But dear all, if we do not know, our eyes cannot see if our brain does not know. So please study it well. Look at your patient, examine your patient thoroughly, and then only you can pick up, because certain lesions patient may not tell. And with that I finish. Thank you very much.
Thank you, Dr. J.K. Sharma.